Okay.
All right, I think we'll get started. Hello, everyone, and thank you for joining us tonight. So we have Professor Lauren Stewart here with us today, and we're hosting this lecture from the Cambridge Institute for Music Therapy Research at Anglia Ruskin University. Before we get started, I'm just going to quickly introduce you to some of the Zoom webinar features. So first of all, we have it set up so only the speakers can share their audio and video. So attendees, please use the chat feature at the bottom where you can introduce yourselves and say where you're from as well if you'd like to. And also for questions, you can use the Q&A function to ask any questions. And you can also see other people's questions and you can upvote them if you find them interesting as well and would like to hear the answers. And then at the end, we'll put those questions to the speakers to answer live. If you're using social media, please use the hashtag CIMTR webinar, and also follow us on Twitter, and that's at CIMTR_ARU. After the webinar, we'll have a survey, so just have a look for that and fill it out for us, and then that will inform our future events. I think that's all from me. I'm going to pass over to Helen Odell Miller, who's the director of the Cambridge Institute for Music Therapy Research. She'll introduce a bit about what we do here, and then she'll introduce Lauren.
Hello, everybody, and welcome. We've had 144 people signing up from all over the world. I hope you're keeping well, and although it's a very difficult time at the moment, one of the advantages is running these types of series so that we have people here from all over the world. So we're very excited about that. We're an international music therapy research and clinical centre based at Anglia Ruskin University, and our major research is funded by JPND and by Alzheimer's Society UK and the EPSRC. We've got projects working across the fields in mental health, working with adults in mental health, and also with people with dementia in the community. And you can find out more, as Jodie said, from our website. But I wanted to welcome you. This is our first big webinar event in our public lecture series that normally takes place in our music therapy centre at Anglia Ruskin University. So I'm really honoured and delighted to introduce Lauren Stewart, who is a colleague and friend and a professor in psychology at Goldsmiths University in London, where she leads a research group in music, mind and brain. And we've been collaborating over the last few years between our organisations. And I'm going to hand over to Lauren now, and thank you all very much. She's actually got her whole team here from the project. So welcome, Lauren, and hand over to you. You're muted.
Oh.
Yeah.
Now, unmuted. Is this good? Okay. Thanks very much, Helen. It's very exciting to be able to share these findings with you. I've never done a webinar before, so it's a first for me. But it's really nice because I immediately had the idea to involve other members of the team in giving the presentation. This work is a very, very large collaborative team effort across many countries and many disciplines, but it's really formed the basis of Katie Rose Sanfilippo's PhD. So I thought it was particularly appropriate for her to be presenting with me, particularly because she's just successfully defended her PhD. And equally, it was a lovely opportunity to have our close colleague Buba Darbo from the Ministry of Health and Social Welfare in the Gambia to also contribute to the presentation. Vivek Glover from Imperial College is also a co-investigator on the project and has been really important in conceptualizing the work, and I'm very pleased to say that she's also on the panel, and I think that some members of our wider team are also out there listening, so hello to any of you. As you can see, I've named everybody at the bottom of this presentation. So just to get started, we're going to sort of pass the baton between us. this project, CHIME for Perinatal Mental Health. CHIME stands for Community Health Intervention Through Music Engagement. And we've just finished a 2-year partnership building grant, which was funded by a very interesting award awarded jointly from the MRC and the AHRC as part of its Global Challenges Research Fund. So this is funding that specifically supports work that can address UN sustainability goals, particularly through interdisciplinary research. Okay, next slide. Anyways, thank you. So we know that it's really important to support a woman's mental health, particularly during pregnancy. And we know this because published research, exclusively from high-income contexts, has shown that actually anxiety and stress during pregnancy can really elevate the risk to the developing fetus, such that that child in later life has twice the risk of having psychological and physical difficulties. So stress and anxiety is not only a problem for the mother, but it's also a problem for the next generation. Possibly that's due to the effects of elevated cortisol crossing the placenta. So, of course, we know that mental health difficulties in pregnancy can be a problem in high-income contexts. We know there's a lot of published research from that setting. But in low-income contexts, there's an exacerbating effect of poverty, which means that these difficulties are roughly twice as prevalent. And coupled with this, there's a real treatment gap. So there's a real dearth of health professionals, particularly psychiatrists. There's about 2 psychiatrists in the whole of the Gambia. And coupled with that, there's specific attitudes and beliefs and stigma around mental health, which prevents people from seeking help to address these difficulties. It's really a high priority to start developing some interventions that are very low cost, low resource, non-stigmatizing and culturally appropriate for some of these low income contexts. Next slide. We know from published research from high income contexts, including some of my own, that singing together, music making in groups, can lift mood, but also can increase social affiliation. And that research has been exploited in many clinical settings. And the evidence is fairly compelling now that musical approaches can reduce anxiety and reduce stress, for instance, around dental surgery, around preoperative procedures, but also around the perinatal context as well. But all of this research has been conducted in so-called weird contexts, so Western educated, industrial, rich and democratic settings. And as yet, nothing has been done in the low-income contexts, despite the fact that there's a very real need for approaches that can be, like music, are low cost, low resource and non-stigmatizing. And this is very much something that was motivating the current project. Next slide. So I just want to say, this is meant to be blank, by the way, just to give a quick picture of how this research project got underway. So Vivek Glover and I were co-supervising Katie Rose's PhD, and we were doing some work around how music listening could be effective at reducing stress and anxiety during pregnancy, with a sample of pregnant women just recruited through the internet. So a UK sample, not particularly screened to have high levels of symptoms, but this was actually a master's student, Chinese Wembube. We were able to publish a small study showing that daily listening to music that had been specially composed for pregnancy was effective in reducing anxiety. At that time, I was in fact on maternity leave myself, so I shouldn't really have been going near any grant calls, but I did see one that was very tantalizing, and it was this joint call from MRC and AHRC specifically for interdisciplinary research that could address a public health challenge in a low-income context. So Vivette and I started thinking about how nice this opportunity would be to expand what we were doing and to look at things through a global mental health lens. And we started talking to a number of colleagues, some music therapists, some ethnomusicologists, about the different possible settings in which we could do some of this work. But it was very important to us, but also to the funding body, that whatever we were doing really made use of the embedded cultural practices in that geographical context. Now, we were introduced to Bonnie McConnell through Ian Cross, who's a co-investigator on the project as well. And Bonnie McConnell is an ethnomusicologist based in Australia. And we were really, really interested to find out that she'd been doing 6 years worth of field work, working with very interesting groups of women called the Kanyeleng in the Gambia, and really documenting the where these groups sit in terms of music and health and the traditional musical practices that can support health there. So this really started to coalesce into a very interesting project, and we formed a large partnership to explore what we could do there. Next slide, please. So just to introduce the team, we're working, as I say, across many different disciplines, from medical statistics, Victoria Cornelius at Imperial College, Vivette, who I've already introduced to you. Our very important partners are Buba Darbo, who's the head of health communication at the Ministry of Health, you'll be hearing from, and Hassoun Cisse, who's the director of the National Centre for Arts and Culture in the Gambia. As I say, Bonnie McConnell's work around ethnomusicology in the Gambia was especially inspiring for the project. And our 2 research assistants working in the Gambia, Malik Gay and Hajara Huma, who I hope might be listening. Paul Ramchandani, the Lego Professor of Play at Cambridge, and Ian Cross. So it was a wonderful, huge interdisciplinary partnership that has allowed us to really explore things from very interesting angles and work together in a very sort of intellectually exciting way. I'm now going to pass on to Buba for the next couple of slides. Katie Rose, can we...
Thank you very much, Lauren. I will just give an overview of the country. That is Gambia. I hope you are all hearing me well. Okay, so as you can see in the map, this is the map of Africa, and the red section is where Gambia is located. It's almost right inside Senegal. So Gambia is in West Africa, and it occupies a land area of 10,689 square kilometers. So it's a small tropical country between that borders to the north, south, and east by Senegal, and it has 80-kilometer coast on the Atlantic Ocean to the west. So the capital is Banjul, and the country has a subtropical climate with 2 variations of distinct dry and rainy season. So the dry season, commonly known as Harmattan, usually starts mid-October and ends around mid-June. Every year with an average temperature of 32 degrees Celsius. So the rainy season usually starts around mid-June and ends around mid-October, with August being the wettest month of the year. And the temperatures can reach up to 41 degrees Celsius within this period. So the official language of the country is English, and the different local languages are Mandinka, Wolof, Fula, Jola, Serule, Serel, and others, about 8 local language. So the total population, according to the 2013 national census, was estimated at about close to 2 million inhabitants, with an average annual growth of 3.1%. So the economy is predominantly agrarian with 510 US. This was in 2013 census. So the economy is primarily dominated by services and agriculture, which account for 59% and 29% of GDP respectively. Some of the key important informations are such as poverty rate, which is 48.4%, and the adult literacy rate stands at 50%. Life expectancy at birth for male and female, for male is 61 and for female is 63. The probability of dying under 5 1,004, and the total expenditure on health as percentage of GDP is 7.3%. So the health sector, the public health sector is divided into, it operates at 3 tier levels in the Gambia, and these namely is the primary healthcare system, the secondary healthcare, and the tertiary healthcare. So the primary healthcare is delivered through a network of primary, secondary, and tertiary health facilities. At the primary level, there are 788 primary healthcare village clusters around circuits of between 5 to 9 villages with a population of 400 and above each. A trained village health worker serves as the serves in this area, and they are supervised by a community health nurse. At the secondary healthcare level, we have 6 major health centers across the country and 36 minor health centers and 42 community clinics. The tertiary has 7 public hospitals in the entire country, which includes only 1 teaching hospital and 1 specialized hospital. And the health services provided through the public sector are complemented by 25 private hospitals and clinics, the 30 NGO clinics and 42 community managed health facilities. So basically, this is just a quick introduction with regards to Gambia, and I hope I will elaborate more on this as we go along. Thank you very much.
Next slide. Buba, do you want to say briefly about the Kanyeleng?
Sure. Okay, thank you very much, Lauren. In the Gambia, as we all know, there are a variety of different musical practice, most of which are participatory music making. And in the context of this research, our main focus is on Kanyeleng groups, as you can see them in the picture. Just to quickly elaborate a bit on some historic perspective regarding the Kanyelengs, who are they and what's their role in the society. I would just say it all started when groups of women who have experienced infertility problem or the death of a child to use musical performance such as singing, dancing, joking, and playing local instruments in order to promote fertility and preventing child deaths. So for several decades, Kanyeleng performance have increasingly taken on roles in health promotion, collaborating with the Ministry of Health. So due to their increasing popularity in the country and their extraordinary skills in singing and using local materials such as gallons, metal balls, or calabash to entertain the public and giving out information on many issues affecting the society, including the sensitive ones, many Kanyeleng groups now include members who have not experienced fertility challenges, but simply wants to perform. So now for this reason, the term Kanyeleng has lost its association with the fertility-related activities, and it simply refers to a form of entertainment or traditional communication. So the Ministry of Health has a long-lasting or strong relationship with Kanyeleng in communicating important health information through local communities. For example, they are now commissioned by the Ministry of Health to help disseminate health information such as the importance of vaccination, HIV prevention, malaria awareness creation, and many others. And they have been very instrumental in many health communication, especially during the Ebola crisis, and as recent as the current pandemic, that is COVID-19. So their performance are also known as Tulungo, or just play in Mandinka. So Tulungo means play in Mandinka. They usually include elements of comedy, which allows them the ability to address sensitive or taboo topics. Their performance are flexible in order to encourage the participation of everyone who is present, and include song, dance, and playing instruments such as bidongo. We call it bidong in the local language, and this is the 20-liter plastic jerry can. So we have something called Jikijo, that is the calabash water drum. And we also have, as I said, metal balls, drums, and other local materials. So because of their pretense and importance in the society, their existing focus on perinatal mental health issues, we look to them as the true experts. So we want to work with them and learn from them, and as we think about a possible program which can address perinatal mental health in the communities. So this group have been very instrumental, and the Minister of Health has been working with them for several years now, and we are trying to collaborate with them in all our health interventions across the country, and they have been very, very much helpful. So this is the more reason we are using them in this research, in this particular research, and we have realized that they have definitely played a crucial role in the whole research domain. Thank you very much, and I would pause here for a moment. Back to you, Lauren.
Thank you, Biba. That's fantastic. Okay, Kayro. Next one.
Yeah, can you all hear me? Yeah, good. So I'm now going to talk about sort of what we had to do before we could talk about developing the intervention. And we really needed to do some foundational work. And so we wanted to address two fundamental questions. So the first question was, how is anxiety and depression understood? How is it talked about? How is it experienced in the Gambia? And do people believe that music could even be helpful? And then we also wanted to understand how already developed measurement tools could be translated and adaptive, and how these measurement tools might perform in a Gambian context. So to address our first question, we ran 14 focus group discussions with a variety of stakeholders. So this included pregnant women, community birth companions and midwives, as well as musicians, such as the Kanyeleng groups, as well as hereditary musicians or griots. And we focused on two of the main ethnic groups that Buba alluded to. So we ran the focus groups in Mandinka and Wolof. And then this is just a picture of Hadra, one of our research assistants, doing one of the focus groups with the Kanyeleng group. And through these focus groups, we wanted to find out what the best terms would be to use when talking about mental health. And what we found was actually there's no real direct translation for anxiety or depression in how we would understand those terms. But in Mandinka and Wolof, there's a general concept of an unstable mind. So in Mandinka, and I hopefully am doing this correctly, Buba, it's Sondamon Tengum Balia, which means lack of a steady mind or heart. And then in Wolof, you have Heldu Dalut, which means lack of a peaceful mind. So we found that these seem to be the most appropriate terms to use when talking about anxiety and depression. And these, identifying these sort of idioms of distress was really important in the translation of the tools, which I'll talk a bit about later. And then we wanted to talk a bit about the contributing factors. And what we found was that there were three main contributing factors. They were economic, social, and spiritual, and they all interacted with one another. So these contributed to a woman feeling mental distress during pregnancy. And so here's an example of a social contributing factor. Being in a matrimonial house, and yet the husband doesn't do anything for you but squander his wealth away somewhere is enough reason to have sorrow. Being in your husband's house and he doesn't talk with you, or whenever he calls you, it means a quarrel. That is difficulty too. So this is a woman explaining the impact the relationship with the husband has on a woman's mental well-being during pregnancy. This was actually a theme that was brought out in a lot of the focus groups that we had. Here's an example of an economic contributing factor. But if you have nothing, no health, you can't have a stable mind. Being sick and poor, one cannot experience freedom of mind. Freedom means that one has a good health. So here it's explained how being poor has an effect on a woman's freedom of mind and subsequently her physical health during pregnancy. Then finally, there were these spiritual contributing factors. And this is something that came up quite a bit in our focus group discussions, and specifically the Kuntafengo, or the spirit husband. And so here's a woman talking about the spirit husband and how the spirit has affected her. Since then, I don't have a child. I dream of that evil spirit, and after I get a stomach pain, I took all kinds of medicine, nothing happened. I did all kinds of medical checkup and they have seen nothing and I still don't have a child. So the spirit husband is believed to take a woman's baby either during pregnancy or after birth, and also is believed to be a cause of infertility. And actually that's one of the historical reasons that Buba was talking about why these Kanyeleng groups exist. They actually do these rituals to fend off the evil spirit who is thought to cause infertility. So in a sense, another reason to work with the Kanyeleng leaders is not only because they're excellent musicians and community leaders, but they're also important spiritual leaders for women. And then we asked our focus group participants if they thought using music would be helpful. And this is an example from a griot, or a hereditary musician. And he said, you ask if music has the ability to help someone with a problem, with being depressed or a sick person. Yes, in fact, that's the reason for the existence of music. Arts and culture, more specifically the facet of the traditional form of arts, are what I am involved in. In such a situation where one is afflicted with problems, it will now be suppressed drastically. Whoever hears a song whilst in the state of depression shall enjoy a degree of relief. So I find this quote quite important in sort of remembering the integral part that music plays in health within the Gambia, specifically around mental health. So basically from that first fundamental study, we found that there are contributing factors, we found some important tools, and we also found that music was thought to be something helpful. So now we needed to find a way to measure mental health symptoms, or specifically anxiety and depression symptoms within a Gambian population. So what we did was we translated two tools that have been used to measure perinatal mental health in a variety of contexts. So first we used the EPDS, which we translated into Mandinka and Wolof. And we also used the SRQ-20, and again, translated this into Mandinka and Wolof. And so both of these tools have been used in African contexts to measure perinatal mental health symptoms. The SRQ-20 was developed by the WHO to be used cross-culturally. So we thought that this was a really important tool to include. The main difference between the EPDS and the SRQ-20 is the types of symptoms that they measure. So the SRQ-20 asks about some of these somatic or bodily symptoms that are related with anxiety and depression, where the EPDS does not ask about those symptoms. So we decided that we were going to administer both of these tests orally, and that was done by Hadra and Malik, who are the two RAs. There's a picture of Hadra again. And both of them are trained psychiatric nurses that have worked in the Gambia doing this. So they both are well equipped to talk about these topics, as well equipped to talk to to pregnant women about their mental health. So we had 221 women involved across 10 antenatal clinics in the Gambia. 145 were Mandinka speaking, 76 in Wolof speaking. The average age was about 27 years. They were about 21 weeks pregnant, and about 3/4 were in a monogamous marriage, and about a quarter were in a polygamous marriage. And these demographics actually map quite nicely onto the general population demographics across the Gambia. So here you can see the distribution of the two scores, and I really just show you this to see the difference. You see sort of this positive skew of the EPDS and sort of a more normal distribution on the SRQ-20. And one reason we thought they might be performing differently is, again, what I alluded to, that they measured different types of symptoms. So what we did was we looked at which items were most endorsed by our population, and actually, or by our sample, and we found that women were mostly reporting that they had somatic, or these bodily symptoms, or anxiety symptoms. So the most endorsed items on the EPDS were item 4 and 5, so which are two anxiety items. Have you been anxious or worried for no good reason? And have you felt scared or panicky for no good reason? Then the most endorsed on the SRQ-20 were some of the somatic items. So do you often have headaches, poor appetite, or do you have uncomfortable feelings in your stomach? And sort of including somatic symptom measurement in a pregnant population presents this difficulty of disentangling what are the symptoms of pregnancy and what are the symptoms of anxiety and depression. But there's actually been a lot of previous work with perinatal populations in Africa that have actually found the inclusion of these somatic symptoms is incredibly important, as they seem to be indicators of mental health within African populations. So then what we really see is that these might actually be two scales that are measuring overlapping but slightly different constructs of antenatal anxiety and depression. So using both might give us a more comprehensive indication of women's mental health within this context. So after that foundational work, we felt that it was good for us to now go ahead and try and develop this intervention. And so this is me actually at the naming ceremony with one of the Kanyeleng groups. And we wanted CIMTR to be a universal intervention. So this means that it includes women with a variety of symptoms, those with lots of symptoms or those with very little symptoms. And this is in line with some of the recent calls in mental health intervention research, which want to move away from this binary approach of mental health. So this idea of whether you have a diagnosis or you don't, to a more dimensional approach, which incorporates treatment for those with high levels of symptoms, but also maintenance of good mental health or prevention of future poor mental health in those who have no symptoms or few symptoms. It's also advantageous to have this sort of population level or community intervention in the Gambia, especially because mental health is stigmatized. So by including women with a range of symptoms and not just screening those for high levels of symptoms, the stigma of being involved in this intervention could be reduced. So to develop the intervention, like Bupa said, we really see these, the Kanyeleng groups as the experts. So we wanted to co-develop the intervention with the Kanyeleng. So we ran workshops and we decided during these workshops what the goals could be, did some role play about what some of the content of the songs could be. And we decided that we'd have a structure of the sessions that would open with a welcome song, close with a closing song, include a lullaby to give women some things they could use once the baby was born, as well as sort of have this meaty middle part that would do a lot of health communication about coping strategies to deal with some of the psychological symptoms of being pregnant, and as well as give sort of a supportive network of other women they could turn to. And doing these workshops was really helpful in being able to have a standard structure of the intervention across the clinics, but giving the women flexibility to use the tools that they have that are specific to their communities. So giving them that flexibility was key. So we came up with a mission statement. So we hoped that all women would leave in a positive mood, would feel part of a socially supportive group, feel empowered to cope with some of the common physical and psychological challenges of pregnancy, as well as have some tools that they could use to seek social support when they needed it. We also made sure to have community health nurses present so they could take attendance and be available for the Kanyeleng if they needed it. And the intervention is 6 weeks long. It's 6-hour long sessions across 6 weeks, and we did it across 4 antenatal clinics in the Gambia. Here are the 4 clinics that we used. It's a mix of urban and rural settings, as well as predominantly Mandinka speaking areas and Wolof speaking areas. So we wanted to get a range of the areas that we used. And in terms of design, we decided that we'd use a stepped wedge design. And this is different to a sort of traditional cluster trial in the sense that instead of randomizing a clinic, the intervention or not, you actually just randomize when they start the intervention. And we had 3 measurement assessments. We had a baseline for the control group, and then the control group had standard care for 6 weeks, and then you had a post assessment, and then you had a follow-up assessment 4 weeks later. And then we recruited another cohort to be in the intervention at the clinics. And then you have the baseline, again, post the intervention, post 6 weeks, and then 4 weeks later is a follow-up, just to sort of investigate the potential longer effects of the intervention. So we also needed to think about what feasibility outcomes we wanted to focus on. So first we needed to find out more about the population of women who attended the clinics. We also needed to ensure that we had tools that were suitable and that could measure women's symptoms. And then there were some more fundamental questions about, could we deliver the intervention? Could we collect the data from the women? And then thinking ahead to the next stage, we wanted to obtain information that would inform the design of a definitive trial in the future. And then finally, we wanted to think about the acceptability of the intervention, not only to the women, but also to the healthcare workers. So I've talked a lot about the intervention, so I want to give you an example of what an intervention session looked like. So this is actually a recording from the 4th session at CIMTR, and this is the middle bit of the intervention. So this is health communication, where they're giving some information about some coping strategies. Okay, so there you can see, so the woman in the brown dress with the flowers is actually one of the Kanyeleng leaders, and you can see she starts the song, and then you hear the drumming pick up and people and the participants come in and dance and sing. So that's just an example of what those sessions look like. They're very lively, and I was actually present at that session, so I can say they're lots of fun to be involved in as well. So what were sort of the results of our feasibility trial? So we had 124 participants included across the 4 clinics in both the control group and the intervention group. And in terms of demographics, they were actually quite similar to the study that I presented earlier. So again, we're pretty representative of the population demographics as a whole. We found that the tools were usable. But what was quite interesting is that across the 3 time points, the skewness that I showed you on the EPDS actually became more severe. And that actually made it harder to potentially measure any further change at some of those later later assessment time points. All the sessions happened, and 72% of the participants attended at least half of the sessions, which is pretty good attendance rate. But interestingly, there was lower attendance at the most urban clinics, Sakuta. So I think in the future, it'd be important to think about potential ways of adapting the intervention or some of the research methods that we use to ensure we have attendance in both rural and urban areas. And then there was an 81% of participants approach consented, so pretty good recruitment rate. And then pretty low attrition with 33% across all 3 time points and 20% between baseline and post. And we saw similar attrition rates between both groups. But then when talking about the timeline, we actually had to shift the timeline forward due to Ramadan. So because during Ramadan, it's inappropriate to engage in these type of music making activities, we wanted to make sure that all the music sessions happened before Ramadan. In addition, there's the rainy season that Buba talked a little bit about between July and October, which can make it difficult for some women to travel to the clinic due to flooding. So these factors are important to consider in terms of a design for a future trial when we're thinking of something like a crossover cluster or a cluster design, parallel cluster design might be more feasible for a larger trial. We also wanted to look at any potential signs of efficacy. And we saw overall a greater reduction in symptoms of those that attended the CHIME group versus those that were in the control group that received standard care. And so, for example, here you see there was about a 2-point mean reduction in the EPDS and the SRQ-20 in the CHIME group compared to the control group at this post-intervention assessment. And this greater reduction is actually also seen, especially in the SRQ-20 a month later at that follow-up assessment. So these outcomes seem to show that CHIME is feasible as well as potentially beneficial for the pregnant women in the Gambia, which is very good and leads the way for a future trial. But we also wanted to think about people's perceptions of the intervention that took part, as well as the perceptions of those that helped facilitate the intervention. So we did interviews with all of the participants that took part in CHIME in the intervention, and we also held focus groups with the Kanyeleng groups, as well as the CHNs who were present at all of the intervention sessions. And we did a thematic analysis to sort of find what themes came out. And overall, we found that people's feedback was positive. So here's an example of a pregnant woman from CIMTR. I realized that before I got pregnant, I used to become worried after the intervention, I am not worried. Your program is good to us, it is beneficial. So we did get lots of positive feedback. We got some suggestions for the future, which I'm going to talk about a little later, as that was a separate theme that came out of our analysis. Participants also reported that CHIME lifted their mood and helped them better deal with stress, leading them to a more peaceful mind. And this was actually reported by the participants as well as the Kanyeleng women and the CHNs. So it makes me have peace of mind, it makes me happy. When I leave here and go home, I don't worry too much, that makes me happy. And then participants also felt that the intervention taught them not only some useful coping strategies, but also gave them other important health information. So here's a pregnant woman from Perinatally. I learned a new lesson from the program. The first new lesson is not to isolate oneself's thinking. When you are pregnant for 6 months, you should also go to the health centers and take your malaria medication for your good health. So again, this is the mix of the type of information that was included within the intervention. And then talking about sort of the social relationships that were formed in the participants within the group, they felt that not only did it create a supportive network of those involved in the intervention themselves, but surprising to at least me was that they felt that the information they gained from CHIME gave them agency to go out into their communities and help and support other women in their communities. So the reach of the intervention actually went beyond just the participants involved and into the wider communities. And so here's an example from a pregnant woman from Kanyeleng. I'm pleased about the program because I isolated myself before and I brought a lot of thinking on my side. But when I took part in this program, now I go out and mingle with them. And then she goes on further to say, right now I'm helping someone and I'm a teacher on my own. So again, talking about going out into the community and helping others based on what they learned in this intervention. Then finally, they gave us some really helpful information or suggestions for the future. And these were primarily around helping cover the transportation costs that some women had for getting to the clinic, which some women found a barrier in being able to attend the clinic. A lot of the Kanyeleng groups and the participants talked about including food in the intervention. And this is pretty typical in a lot of gatherings in the Gambia to include some sort of food or sharing food. And finally, a lot of the pregnant women and the Kanyeleng women talked about extending the intervention until birth. So it only lasted for 6 weeks, and a lot of women had a couple of weeks before they then delivered. And a suggestion for the future was to extend it until the women gave birth. So when thinking about a future trial and implementing some of these really good suggestions, we need to think about sort of sustainability. And I think this is where our partnership with the Ministry of Health and specifically BUBA is crucial. So I'm gonna give it to him where he's gonna talk about that.
Buba, are you still there?
Yes, thank you very much, Katie Rose, for that brilliant presentation. So this shows that our project, the CHIME, have definitely been very effective. So I will just talk about the partnership and sustainability. As we all know, most often people have the belief that the most traditional practice at odds with most of our contemporary health initiatives. But to me, I think CHIME have come to prove this idea wrong. So it's not all traditional practices that are definitely not in line with our health initiatives. So we have seen from Katie Rose's presentation that this model that we are using definitely have been very much have proven very much effective in alleviating the moods of our expectant mothers. So this is something that definitely have yield a very great positive results as far as perinatal mental health is concerned. So in order to explore more on these, I think the Minister of Health is definitely very ready to partner with the CHIME and see how best we can scale up these initiatives. We have seen, women, coming out, giving out testimonies. We have seen women, very proud of the initiatives, and they, in fact, did not want this research to come to an end. So a lot of women have confronted us, telling us that we should continue with this initiative because it has helped us a lot. So this is something definitely we need to roll out and expand across the whole country. It's not a great deal of money in UK terms, but it's still a large amount to find in a Gambian context. So we have been working with other agencies, of our health programs, and I think something of such nature can be supported in terms of interventions, and then how best we can also sustain these particular intervention that we have just embarked on. I would say one of the things that we are looking forward as a ministry is for to introduce such kind of traditional practice, that is Kanyelengs, using Kanyelengs in our reproductive and child health clinics. We have seen during this period, women would go under a lot of queuing and time waiting before they got any services, because normally this is done once in a month for each woman or a particular child that have been given these services. So this period definitely is sometimes characterized by women waiting for long, bored in the queue, and they are not actually very happy during this period, and because they have to stay very long without doing anything, and waiting for their services or waiting for their turn. So what actually happens, this have in fact some negative consequences on the turnout of many women. When they finish, for instance, they finish the basic services like immunization, to bring their children for weighing sometimes becomes a problem, because they are always bored at the clinic. So this is such of this type of intervention, for instance, having Kanyelengs at the clinics, performing while women are waiting for their services, that can actually entertain them and also give them some very important health messages as they are waiting for their services, and will be entertained, and they will be happy to join the clinic sessions. So these are some of the things that the ministry also have been yearning for quite a while now, and I think and I believe these our CHIME system or style of intervention can also be used in this aspect, where ministry will use Kanyelengs across the country in all the reproductive and child health clinics to give their services, and it will be integrated into our policies as officially contributing to the health and welfare of women and children in this country. So I think this model, and also, of course, many other models can also be explored, and we can see how best we can carry forward this system, and so that we can have this kind of integrated into the system, into the existing system, and then it will definitely be sustainable as a country. So I think this is an opportunity that we need to explore, and I think we need to first expand and see how best we can explore on such kind of set the stage, and I think just to build onto this and see how best we can move with it as a country. I think that will be very, very much helpful, and we are very much looking forward to such kind of great partnership, and in the future. Thank you very much, and back to you, Katie Rose.
Okay, thank you, Buba. So nice to hear at the ministry perspective, isn't it? So yeah, I just really, drawing things to a close now, just to really underline the fact that this was a feasibility study and a partnership building grant, a two-year grant, but we've actually managed to do quite a lot of work in those 2 years. But of course, after a feasibility study, what you need to do is the full-scale definitive clinical trial, and that's where we're at now. So we're seeking funding from the Joint Global Health Trials in September to really fund a fully powered clinical trial that would also extend into Senegal. That's because, so the Gambia is a very small country. Senegal is approximately 8 times the size of the Gambia, and many regions of Senegal have got similar musical cultural practices. The groups are not called Kanyelengs, they're called Bajenu Gox, which literally translates as aunts of the nation. And the origins of the Bajenu Gox is slightly different to the Kanyelengs, but nevertheless they fulfill a very similar purpose. And we think that sort of extending across Senegal and the Gambia would be preferable to staying within the Gambia, because of course we want to show that we can have as large an impact as possible. Related to that is the fact that we actually think that, given the universality of musical approaches and music making, that we think that chime with the necessary adaptations could be very generalizable to many other low-income contexts. Of course, they're all culturally different, but nevertheless there are often particularly women's groups who work a lot with music. I mean, the Kanyelengs are absolutely a perfect example, but nevertheless there will be different versions of that in many different contexts. Yes, so in our larger trial, we're going to be embedding process evaluation and also a cost effectiveness package to really have a close look at how much investing into this period of a woman's mental health what difference that can make in terms of economic savings, in a way that's already been done in a UK setting through the Global Maternal Mental Health Alliance, and now it really needs to be done in a more low and middle income context. As Buba alluded to, we already have to be thinking about how to implement this kind of intervention, assuming that we get a positive outcome on the definitive trial. What next? Who's going to pay for this to be rolled out across the country? And I think actually in principle it's a very sustainable intervention, because the Kanyelengs are already working in these ways at a community level, and they're already working with the ministry in a paid capacity to do a lot of their public health campaigns. So of course there's models around philanthropic giving and aid agencies funding these kinds of interventions, but really the priority for us is to think about whether or not such an intervention could be self-sustaining, because of course that will have more long-term consequences. So I think I'm right in saying that is that the final slide, Kediwes? You've been driving this. Thanks to you all for listening, and we're very much looking forward to having a little bit of discussion and questions from you all. Thanks.
Thank you so much. There's a huge amount of discussion going on about one big question about whether this could be generalized. That's mainly on the chat, and then there's some very specific questions which Jodie's going to coordinate. But I just wanted to throw this open, and it's very specific, and you spent a long time sort of looking at the protocol in a way and really making it culturally specific. But interestingly, and there are quite a lot of people here I can see from the chat who work in this field or in related field, like in the neonatal units after birth, but also people who are experts in this field saying this sounds quite generalizable. So I wondered if any of you wanted to comment on that, given that you've been so specific and culturally specific about where the study is taking place. Just to kick off.
Yeah, sure. Well, yeah, of course the specific setting was quite unique to the Gambia, and that was really because I think that having somewhere where you understand a lot about the traditional musical practices and their existing uses for health is a really sort of firm foundation to start from. And of course, we have Bonnie McConnell's work to thank for that, really, and also the established partnerships. So I think what you need with these interventions is a blend of the real specific cultural understanding, but then the ability to, if you like, operationalize that at a higher level, which is what we did. So we essentially said, you know, this is around building socially supportive networks, thinking about positivity and resilience and coping mechanisms, and really capitalizing on the fact that in a country where there's such low literacy, the use of song as a messaging device can be really effective. But those parts of the protocol can be operationalized regardless of the specifics of what's going on musically. And in fact, it was, you know, even across the 4 different antenatal clinics, 3 of them were Mandinka, 1 of them was Wolof. They differed whether they were urban or rural. So what we had to say was, you know, this is the structure and this is the content that we want you to get across. But of course, you have to draw on your own repertoire, your own ways of working. And we brought the 4 groups together in order to sort of have a overview of, like, okay, these are the different local ways of working, but there is a sort of a higher level cohesion across the 4 groups. And then actually we videoed 2 of the sessions at every antenatal clinic so that we could go back and watch those and code them for whether or not the key ingredients of the intervention were happening. And we found that they were happening. So that assured us that it wasn't just, you know, a very nebulous type of do whatever you want kind of thing. But our real core parts of the protocol were coming across.
Thank you.
Oh, I was just going to say, I saw Vivette raise her hand as well, I think.
Well, I think it's interesting to think how generalizable it is. I mean, there's actually a great need for more intervention in the UK, even though we have much more psychologists and psychiatrists than they do in Gambia. Still, most women who suffer from anxiety and depression in the perinatal period don't have any help. And I think the idea of it being universal, so there's no stigma, that still would be very helpful here. So I think singing music groups for antenatal clinics here is something that will be explored as well.
Thank you. So I'm going to hand over to Jodie because there's a list of questions.
Yes, there's a few here waiting. So the one, I'll start with the easy one, the pronunciation one. So I consistently miss this word throughout the presentation. Is it Kanyeleng, K-A-N-U-L-E-N-G, or Kanyeleng, K-A-E-N-I-L-I-N-G?
Oh, yeah, sorry. It's Kanyeleng, K-A-N-Y-E-L-E-N-G, Kanyeleng.
Okay.
In fact, our colleague Bonnie has written a fantastic book called Singing the Unsayable, and it's all about the Kanyeleng and their activities. So Singing the Unsayable, if you search for that, it's a fantastic book.
Perfect, thank you, Lauren. All right, and then the next question, which has the most votes. How did you check the translated versions of the questionnaires to ensure that they were culturally sensitive while retaining their construct validity?
Sure.
I can probably take that one. So we actually did a pretty rigorous translation protocol that was based on suggestions from the WHO, as well as a couple of other suggestions from prominent people in perinatal mental health or mental health tools in general. So what we did was we had people translate it from English into Wolof and Mandinka. And then we took those translations, those initial translations, to a translator who was separate from the research team, who's actually employed by the National Center of Arts and Culture as a professional translator to back translate those into English. And then we took those back translations to a panel of experts, which include mental health experts in the Gambia, as well as people part of the National Center for Arts and Culture, linguistic experts, as well as some of the experts on our research team, to work through that back translation to make sure that any changes that were made, they made sort of final changes based on what those back translations found. And then one of the main purposes of that second sort of foundational study, so as we actually did a pilot before we did that, where we went out into the clinics for one day and trained the RAs in how to sort of do the questionnaires orally. We then piloted it with some pregnant women at an antenatal clinic and got feedback from the women about their experience of it. So we were pretty careful in the translation methods that we did and making sure that the RAs were trained in how to do it consistently throughout the study.
I wonder if I can just jump in there just to make a point that it was very interesting to discover how different it is delivering these questionnaires in an oral way. So we had to do that because many of our participants lacked literacy required to read it. So of course our research assistants were reading every question, and even if we make it clear, you know, there's 4 different responses, you know, yes very much, yes moderately, yes a little, it's very difficult to stop participants from jumping in as soon as they've heard the question to say things like, oh yes, I had a stomachache last week and it was, you know, it was related to this thing that I, you know, to sort of treat it as an interview. So that we had to do a little bit of adapting, such that, for instance, with the SRQ20 is different because it's yes, no, it's just a binary scale, but EPDS, there's 4 response options. So we initially asked the question and then said, yes, if they said yes, as opposed to no, we would say, okay, yes, very much, yes, moderately, yes, a little. And it might seem like a really small point, but actually it's something that hasn't been written about in the literature, but actually the difference in delivering things through a written form, as we're used to, versus delivering it orally, is quite a change. So it's, yeah, that was just something of interest.
All right, thank you both. Next question. Did anything surprise you about the qualitative data you gathered from the participants?
I think in terms of, well, we did the 2, so we had the focus group discussions at the very beginning, but in terms of the qualitative data that we got after the intervention, I think that, like I said, the one thing that really surprised me was how it impacted the communities. So a lot of the participants talked about, oh, there was a woman who I saw was struggling and I told her, make sure that you don't stay alone, that you find friends to talk to, or sort of the Kanyeleng women would talk about how now I know this information and I'm going to use this information to help others in my community. So I think that was not something that I expected in terms of the qualitative data that came out of the feasibility trial, was sort of the wider impact it had. And one of the CHNs picked up on the fact that, you know, we'd have them, that they were held at the antenatal clinic, but there were sometimes women that came from different villages to this one antenatal clinic. And then when you have women from different villages learning this information, the impact that you have to those different villages, the CHN talked about how it's not just one village that's getting this information, it's multiple villages around this one antenatal clinic. So I think that was something that was really surprising to me, and something I actually enjoyed reading when I read through all of that data.
Just to jump in as well, I remember we were quite pleased also when we found out that a couple of the participants had in fact recorded the sessions on their phones, so that when the intervention period ended and they were no longer meeting up in these groups, they played the videos at home to sort of re-experience the session because they didn't really want it to end. And that's something that we hadn't predicted at all or thought would happen, or, you know, hadn't occurred to us that they might actually want to video the sessions on their phones for later use.
I think that I was surprised by
okay.
No, go ahead.
So I just go briefly and then I was surprised by the different understanding of anxiety and depression. And I think that it's something we probably should be aware of, again, thinking about the UK, of different immigrant populations, that in helping them to deal with anxiety and depression, one should realize they may be more willing to talk about or feel more about the somatic symptoms than the standard symptoms we look at. And also the concept of spiritual attack. I mean, I know that's very strong in Nigeria, but also in Nigerian immigrants here. So I think that we should be aware of music therapists working with immigrant populations in the UK as well, that they may have different concepts of anxiety and depression. Sorry, Buba.
Yeah, so I was going to say another thing that also definitely surprised on suddenly when they started building that bonding together, that sense of closeness together, and they in the end not only give them the performance, but they were also kind of supporting them, bringing them along to the sessions, going home with them together when the session close. So we are all parents and the pregnant women, which was really very, very good.
Okay, we've got 2 more questions. We've probably got time for both of them. One is, did participants indicate? Oh, well, actually, we've got 3. We maybe, if we normally go on till 6:45, 7. So I think we could address these quite shortly. So the first is, was the intervention mainly based around singing, and how was the music created? I think you said a bit about that. Maybe you might want to.
Yeah, so I think, oh, sorry. I think the video was a really good example of what it looked like and what it sounded like. It was singing, drumming, dancing, and in terms of how the music was created, it was all created by the Kanyeleng women during these workshops, and a lot of it was actually based on traditional songs. So maybe they have sort of a chorus that everybody knows the chorus of that song, and then they would improvise on the verses to give the health information. There's lots of call and response as well, sort of allowing the participants to share through improvisation or through singing along. So the music was all created by the Kanyeleng groups, and the workshop was really instrumental in sort of thinking, working with the Kanyeleng women to think about what songs they could use, what adaptations they could do, and things like that.
So they're like they were like the facilitating group, really, which I think when you've presented this, you've also presented other musical examples that showed more detail, which is much easier when we're not on this video link. But I think we'll go on. Jodie, do you want to?
Yeah. So the next question is more about your experience. So you've talked about the impact on women in the project, but this person's interested in the impact of on you. Do you have any reflections on how being involved on this research has had an impact on yourselves?
Yeah, for sure. I can honestly say that this project has been the most interesting piece of work that I've ever done. And it's also very surprising and unexpected project. I think one of the main lessons is that you can sort of jump into an area that you don't necessarily know a huge amount about, and you can draw together the strands to make a partnership. I mean, the partnership has just been phenomenal, really, to work with such a range of experts. And I actually find it now very difficult to think about research questions that are not related to problems, right? So I think it's actually changed my mindset. I now don't really understand why research that doesn't have a direct impact. I find it difficult to do such research, really, or to think of it as interesting. So I'm enormously grateful to have had the chance to kind of jump into this new area. Yeah, I think also sometimes it's easier to think in a new area, right? Because you're not, I mean, to write a grant even in an area that you haven't worked in before. I think the reason that came off was because I just found the whole thing so incredibly interesting. And, you know, the more people I was introduced to and the more conversations that I was having and drawing it all together. And then, yeah, I mean, Katie Rose basically took it and ran with it, and sort of having these partnerships with the ministry and with Buba in particular, which really couldn't have happened without Bonnie McConnell's sort of foundational work over 6 years or so. Yeah, I mean, it's doing interdisciplinary work, I think, is quite difficult in a way, but I think the key thing is to try to work out what everybody recognises as being the most important, tangible, tractable questions. And once that's in place, then the rest of it can sort of follow, really. What about you, Katie Rose?
Yeah, I think this is sort of, obviously because it was my PhD work, I sort of didn't know that much before this, but I think I've been spoiled in the terms of having such an amazing team. And I think I've really, one thing I think, like Lauren said, I think it's really instilled in me a want to do research that has some potential impact. And I've become more and more passionate about women's mental health through this, I think, as well. I think also in terms of relationships and understandings, you know, I sort of got involved in a culture that I didn't know much about. And I think it's a testament to Buba, as well as Hadra, Malik, and Hassoum, and Bonnie for sort of taking me under their wing and really introducing me into the beautiful musical culture of the Gambia. And I think that's something that I really gained from this project. But I'm actually interested to know what Buba thinks, if Buba's there. Is he there? He might not be there.
We can't hear you if you're speaking. Hello, Buba.
He might have internet at this moment, but that's okay. But I do think, yeah, the relationships I formed during it, I think are really important and have been fantastic. So.
Thank you.
Fabulous, thank you. All right, one more question here. Did participants indicate that they would like to attend further sessions?
Yes, for sure. That they complained that it didn't continue till when they at least delivered. And the reason for that was, you know, really in sort of developing a brief intervention is often the way to go, because it's just more feasible and more tractable, really, thinking about the attrition and what's manageable. But, you know, I remember Catherine Carr presenting and saying that, you know, very often at the end of the intervention, you get sometimes the end of the intervention can sort of mitigate any potential benefits of the intervention, because people are kind of, really unhappy that things are coming to an end. And the fact that they were playing the videos at home after the sessions finished was really quite revealing as well. So, I mean, perhaps a future iteration of this work could also include like a postnatal period as well. Certainly at the start of, before this work commenced, we were talking with people like Helen Schumark, who does such nice work around sort of neonatal period and continued singing. And of course, that's a very important part of the perinatal period as well. But the logistics meant that we had to focus on a relatively short period of time, really. But we did include, in every session of the intervention, the Kanyelengs taught the women a lullaby, because there's some evidence to suggest that, in fact, the younger women now don't retain this repertoire of lullabies. So it's knowledge that's held by the elders. So they were passing it on to the participants for use after they deliver, which I think can sort of expand the potential impact of the intervention into that postnatal stage. We didn't measure things postnatally because it was just a feasibility study, but in the definitive trial we do have a postnatal data collection period as well.
Yeah, there's so much more to say, but we've run out of time, and it is quite you know, it's a shame we can't have the informal discussion part that we often have at the end of our lectures, but thank you all so much. It's been really fascinating, and I know that there's a huge amount of interest, and there are people working on you know, future research designs in this area, I know as well, who I'm sure will want to get together. And there's just been an announcement of the music therapy charity for a sort of kick-off grant for people who want to work towards a large bid or consortium, but who want to bid to sort of work within a network, which you know, people might approach you. You've got your, you know, your large grant already being developed, but I think from what I can see in the chat, this has been a really important area that's developing in our country too. So thank you all very much. And Jodie, I'm going to hand over to you. And thanks to Jodie, I want to thank you publicly for making this work with the technology and inviting everyone. And we've had over 100 people joining in. So thanks to you for giving your time to present, and for the whole team to be here, and then also to all the participants. And I'll hand just over to you, Jodie, for the final part to let everyone know what we're doing in the future.
Yeah, so thank you to all the speakers, to Lauren, Vivette, Katie, Rose, and Buba. And thanks for offering to do this as a webinar instead of a live event. It's really great that we pulled it off. And it definitely was a learning experience for me. But thank you for all the attendees for coming. And just a reminder that there's going to be a survey that you can fill out that Zoom will link you to when you sign out of the webinar. So fill that out for us. You can let us know if you want more online events in the future. And then in June, on the 8th of June, we have Dr. Jonathan Poole, who's a researcher at Anglia Ruskin University, who's going to be talking about his work doing music therapy with children with disorders of consciousness. So do register for that one as well. And we look forward to seeing you all then.
Thank you. Thanks so much.
Thank you.
Bye, everyone.
Bye-bye.
Thank you so much.
Thanks for having us.
Thank you, guys.
Bye-bye.
Bye.
Bye.